I want to speak about some studies that we performed and in some capacity tried to tackle some of these issues that I described. So first of all, these studies are based on a multi-echo DSC, called dynamic CGPI, which is a spin and gradient echo. Um, it has 4 echoes. It means it's just like acquiring 4 different perfusions simultaneously, though. So it doesn't increase the scanning time. It's everything comes at the same timing as a single perfusion. More importantly, the first 2 echoes are 2 gradient echoes with different echo times, and then the third one is an asymmetric spin echo. The fourth one is a spin echo. We will focus on echo 1 and echo 2, which are 2 gradient echoes, just like a classic DSC, but with 2 different echo times and acquired simultaneously. The first study I want to show is this concept of using these 2 echoes, echo 1 and echo 2. We called it multi-echo perfusion, but since we're only using 2, we can also call it dual echo perfusion. Some institutions have a dual echo perfusion with these 2 gradient echoes without having all 4 echoes. So you can also see dual echo perfusion in the literature. If you have these 2 echoes, you see that the one above is more T1 weighted. You see the signal drop when the bolus comes, but then a lot of T1 effects and overshoot of the curve. The second one has a little less of that. So it's 2 different levels of T1 sensitivity of the same sequence that are acquired simultaneously. But once you have 2 echoes, you can use the block equations and extract the pure T2 star component, so without T1 effects. And on the other side, the pure T1 component with no T2 star effects. You can see that this T1 component is essentially a DCE. It's a purely T1 weighted sequence, which is, again, this is not acquired. This is calculated from the first 2 echoes. Whereas the pure T2 star sequence has no T1 effects. You see that the curve goes down when the bolus arrives and then never gets higher than the baseline. Of course, the T1 component you can use for a DCE analysis, get K-trans and V if you want. And you can also quantify what is the delta R1 at steady state. So what is the increase in delta R1 at the end of the sequence, which quantifies the post-bolus T1 effects, essentially. DSC, the DSC, of course, you can use for DSC analysis, like PSR and CBV. In this study, it's an approximation. It's not really correct to do this, to get PSR and CBV from the same sequence. I mean, it's not ideal, let's say, but let's put this on hold because it is not the main focus on the study. And then from the delta R2 star, you remember how before I said delta R2 star single echo? Well, this is a delta R2 star dual echo and has no T1 contamination. So it will never go below 0, as we said before. And the delta R2 star residual at the steady state tells you something about the T2 star leakage effect. Now, T2 star leakage effects and T1 effects, T1 leakage effects, we can combine, and these are quantitative metrics, in trait, which is a quantitative metrics that calculates how much T2 star leakage effects compared to T1 effects we have. So in terms of doing DCE and DCE simultaneously, so first of all, we did not invent that. That was proposed before in other studies. And trait also was proposed in a single study that was mostly like a simulation and mice study. So what we did here is we combined ideas from different studies and proposed an integrated flowchart. So compared to DSC and DCE, traditional ones that are done separately, here we can get both with one sequence, which is faster, and only with one contrast agent dose. Reducing contrast agent is important for patients with kidney disease, not really, because patients with severe kidney disease should not receive contrast agent at all. There is that concern about chronic deposition of contrast agent in the deep gray matter. This is debated because we are not sure what are the clinical counterparts of this, but I also want to add there are ecological, environmental reasons for we should be concerned about the amount of gadolinium we're constantly using. So if we can reduce that and obtain the same results, that should be desired. A good question would be, okay, but this DCE that we get from multi-echo DSC, is it the same, exact same as a classic DCE? It is in terms of signal over time, like that's a purely T1 weighted signal. However, the sequence has some differences. First of all, it's an EPI, which classic DCE sequences are not. So the air tissue interfaces, like at the temporal bone, it will create artifacts, or other artifacts are the well-known distortions of the frontal lobes, temporal poles, and so on. The spatial resolution is lower than a classic DCE, and it's a bit shorter, but that can be fixed. Like you can decide to have multi-echo perfusion as long as you want. So the concept that is interesting about trait that we mentioned trait, it's a refined parameter that quantifies T2 star leakage effects normalized by T1 leakage effects. So in a way, it's a refined version of PSR, and in fact, it does correlate with PSR. The difference is that PSR is going to change when you change the flip angle and whatnot, but trait should not change because it's based on quantitative estimates of delta 1 and delta 2 star. Let's skip the speculations about the biological explanations because it's a bit speculative. This is just an example of how you can calculate all of these quantitative metrics, including K-trans, CBV, trait, and whatnot from the same sequence. And I want to skip to the next study that I wanted to mention. This is something that we came up with, and we're trying to take an extra step. So as we said, from two different echoes, we can disentangle T1, R1 over time and R2 star over time. So there are quantitative relaxation rates that are linked to T1 effects and T2 star effects, but they are quantitative metrics. Once we get these, let's call them ground truth relaxation rates, the idea was to re-input these curves inside into the block equations again. So we use the block equations to derive these curves, but now we can use again the block equations from these curves to input whatever flip angle, echo time, repetition time that we want, and simulate what the T1 weighted and T2 star weighted components of the curve would look like with a certain combination of pulse sequence parameters such as flip angle and whatnot. And then we recombine T1 weighted and T2 star weighted components to get ultimately a synthetic perfusion that has whatever combination of parameters we want. So as you can see, the teal one, like light blue, would be very high in terms of T1 sensitivity because it has high flip angle, low T, and whatnot. And then the other curves are less and less T1 weighted depending on the pulse sequence parameters that we chose. So these are the technical steps that I just described. The first clinical application that we thought for this is to solve that issue for which CBV optimized DSC and PSR optimized DSC have different parameters. It doesn't matter what parameters you use to acquire, as long as you have two echoes, you can synthesize the curves with any parameters that you want. So you do one acquisition with two echoes, and now you can set the parameters to the guideline compliant CBV optimized curves that have very little T1 effects, and you can quantify an accurate CBV. Or you can choose to have parameters that are very heavy in T1 effects, and you can quantify PSR. The clinical application number 2 that we thought about is, you remember how I said that you cannot really compare the curve shape or the PSR values to external studies because most of the times they will have different parameters than the ones that you used for your acquisition. Well, now, if you have a way of synthetically changing those parameters, you can match synthetically those parameters to whatever study of interest that you have, and then compare your results with theirs. So in this case, we matched our glioblastoma cases uh, in terms of PSR values. And we matched the parameters of a certain external study. We show there is no difference with their glioblastomas, but there are clear differences with their lymphoma cohort. And the same for another study where we matched to their different parameters. And we also show that if we simulate a preload, we did not show any difference with their lymphomas, which is consistent with what they found, that they could not differentiate glioblastomas and lymphomas after preload. And this is just a pictorial example of how we can change the parameters and obtain different shapes of the curves with different synthetic parameters. So overall, dual echo perfusion, or the first two echoes of multi-echo perfusion that we use, can help doing this task of DCE, DSC for CBV, and DSC for PSR. All three of them, thanks to the block equations and the synthetic approach. And doing all three of them is not possible, not even with repeat sequences, because you can only do two maximum. And additionally, we only use one sequence and one contrast agent dose. And the other idea would be to harmonize data from multiple institutions. At this point, you wouldn't even need to coordinate everybody to acquire all the data in the same way. As long as they acquire two echoes, you can fix the harmonization of the parameters on the back end and just match the parameters synthetically after. This is the idea. Finally, a couple of things. I wanted to show how beyond dual echo, dynamic stage API have, as I said, other echoes that are spin echoes or asymmetric spin echo. An application for this is vessel size imaging. So we can use all of the information because we know that spin echo DSC and gradient echo DSC are sensitive to different sizes and calibers of the vessels. We can use all of this information to estimate the size of the vessels in each voxel, and it was shown that it correlates with the vessel caliber from histology. And finally, another example of a dual echo, but with spin echo and gradient echo, so not two gradient echoes as we did, but spin and gradient echo, can tell us something about the size and the nature of the vascular structures and the vascular architecture, whether it's more veins or arteries, and what is the caliber of these vessels by comparing the bolus arrival in the two different perfusion techniques. Finally, the concept of pseudo-resting state, just two slides. As you know, which is another advancement that is related to perfusion, as you know, resting state fMRI, the concept is we have signal over time, so again in a fourth dimension, of different brain regions, and we know that brain regions that are functionally connected should have some correspondence in how the MRI signal oscillations are synchronized over time. Because if the oscillation is in phase to some extent, this is not a correct term, but just to give an idea, it means that those two brain regions are speaking to each other, that their synapses are firing simultaneously to some extent. But what is this signal over time that we are measuring in functional MRI? It's a T2 star weighted signal, the same type of signal that we're measuring in perfusion. So the idea was this would be a resting state fMRI with T2 star weighted signal over time. The idea was perfusion is also a T2 star weighted signal over time. If we can cancel out the bolus of injection of contrast agent, and we can cancel out it by modeling it and then subtract it from the measured data, we can obtain the same almost T2 star oscillations over time, just like in a resting state. And in this article, we showed how the default mode network, the motor network, the language network are pretty similar with the actual resting state and the pseudo resting state. One of the limitations, in addition to the fact that you have to subtract out the bolus, is that usually perfusion studies are much, much shorter than resting state, so 2-3 minutes versus 10 minutes or something. So definitely it's going to be more of a noisier sequence to do fMRI on. But potentially it's a method to unlock functional connectivity analysis from retrospective perfusion data, which is very, very interesting. So overall, we talked about brain tumors, we talked about perfusion MRI, DC, DSC, and leakage effects that are already applicable in clinical practice, and we talked about the technical premises. We talked about clinical applications real fast, and then we went over multi-echo perfusion applications and how it can help to some extent to face the open issues. And then finally, very briefly, we introduced the concepts of pseudo-resting state. Thank you.